Good evening. Thank you very much for inviting me back to the SAN Prostate Cancer Support Group for really an update about what's been happening in the management of prostate cancer up to 2017. So it's been a very exciting time, and I thought one of the best ways of managing the complexities of all the data that we're going to present today is that I thought I'd start off with the conclusions, and hopefully during the talk I'll be able to validate those conclusions and reinforce them along the way. I think probably the most important message, and really the main take-home message I want to give you tonight, is that we are all individuals, and everyone's disease is quite unique based on the pathology of the disease and also based on the individual patient characteristics. And so that's something that we'll talk about tonight. The other important message is that we've seen really marked progress in the way we treat prostate cancer, particularly over the last 5 years. We're now in a situation where we have many treatment options, and really the main issue is becoming how we sequence and time the various treatment options such that we're able to give our patients access to as many of the drugs that are available as possible to try and increase the duration of benefit for as long as possible. Probably one of the other important messages I want to get across is that we've seen a real shift in the way people research and approach the management of prostate cancer, to a move away from nihilism, how it used to be seen, to something with quite significant optimism. And that's really because of the results of a number of studies. We're now starting to see much excitement and enthusiasm in developing clinical research and improving outcomes. The other thing that happens is every 6 to 12 months, we're getting the development of new drugs which become a new part of our treatment paradigm, and the goalposts keep shifting. And how we incorporate the previous data that has been evaluated and shown to be effective into the continuously changing and progressing new data. And the other thing I wanted to highlight was the importance of clinical trials, both because it provides our patients today with access to drugs that they otherwise wouldn't be able to obtain, and also because it's a way that we can continue to improve the outcomes of our patients in general. I thought it's also important to highlight what we are not discussing tonight, largely because I wanted to make sure that you guys appreciated the significance of all of these things, but obviously not something that we're able to address in a short discussion. The first thing I'm avoiding is PSA screening. That may come up in question time, but as you can imagine, that's controversy in itself, which would take the whole discussion. Radiotherapy, surgery, androgen deprivation therapy, bone health, the new imaging techniques, sexual health, the importance of managing metabolic disease, and as we see our patients living longer, we need to be sure that we're managing all the comorbidities and associated problems that come with androgen deprivation therapy, such as managing the cholesterol, the diabetes, and the bone health. We also need to understand the importance of palliation and good symptom control, and obviously because of the difficulty in understanding individual patients' situations, I obviously can't discuss individual cases. You're probably sitting there saying, well, that's a long list. What are you actually going to talk about? And hopefully there will still be many other things to discuss despite those things we're not discussing. The first slide I want to put up is a slide quoting a great philosopher of our time, Monty Python. Now, Monty Python stated that we are all individuals, and I think that that's a very important message, and particularly in prostate cancer. We rarely see that each patient's disease is quite different to the next patient, and that's very important for us in making our decisions about how best to treat an individual patient. So the factors that come into that is the heterogeneity of disease, which basically means the spectrum of disease within prostate cancer. So there's some patients with prostate cancer where it's a very biologically aggressive disease that needs treatment tomorrow. And then we've got other cases where the prostate cancer biologically, what it looks like under the microscope, is very slow growing, grumbling disease that probably doesn't require urgent treatment. And there are a number of factors that help us understand that, including the Gleason score of the tumor, the way the tumor biology has behaved, where it's metastasized to, things like the PSA doubling time, and all of those factors are taken into account by your treating doctor to make a decision about the need and the timing of further treatment. Other factors that come into account is whether a patient is symptomatic or not. So if a patient is symptomatic, we know that we need to get into treatment faster than in someone who's just got a slowly growing, rising PSA. We can afford a bit more time before we start treatment. Often we understand that prostate cancer occurs in older patients. And that's not necessarily true. That was a mantra that was taught when I was in medical school, that you don't really need to worry about this because it's a disease of older men. Now that really isn't the reality of what we experience in clinical practice these days. The first thing to say about that is that even older men now are living many years, and so those patients, their prolonged survivals need to be taken into account when we manage their prostate cancers. And also we're starting to see prostate cancer in younger men. The other thing that's happened is the way that we detect prostate cancer, both with PSA and some of the new interesting imaging modalities, has shifted the way we can detect disease, and that also has an impact in making decisions about how to treat disease. So as you can see, gathering a story about a patient's disease is what is important in defining how best to treat the problem. And it's clearly quite unique. And that is what happens with the doctor-patient relationship when you're in the consultation with the doctor evaluating all of those features, and together with the patient makes a decision about the optimal treatment. So we know prostate cancer is a big problem in Australia. It accounts for 20,000 new diagnoses a year. These are 2011 statistics, and updated statistics are due soon. We know that 30% of all new cancer diagnoses in men are due to prostate cancer, and these are similar numbers that we see with breast cancer. And until the last sort of decade or so, there was not much interest in looking after this problem, largely because there wasn't a big voice for our patients. And over the last few years, with organisations such as the PCFA and support groups and these sorts of organisations, prostate cancer patients now have a voice. And I think that's been very important in driving some of the research and driving some of the treatment options and supports for our patients. The statistic at the bottom demonstrates the change in 5-year survival rate of patients over the last few decades. And from the early to mid-80s, the 5-year survival rate of a patient with prostate cancer was 58%. From 2000, if you were diagnosed between 2006 and 2010, the 5-year survival rate is now 92%. So we can see a dramatic improvement in outcome. Now that is not all because of treatment progress. Certainly some of it is. Some of it is because of a process called stage shifting, where we diagnose things earlier because of various screening programs, etc. But it still is a very important number to highlight how much progress we've seen over the last few decades. I like this slide because it kind of outlines what our options were 10 years ago. If I had a patient diagnosed with metastatic castrate-resistant prostate cancer, I really had one or two options. Now I have all of these options, which is really quite dramatic in how we can change the way we treat this disease. The challenge now is working out how to sequence all of these different agents and how long we should keep these agents going before we shift between agents. And as you can see at the bottom, highlighting the importance of clinical trials, which really are important in progressing the outcomes of our patients. What I'll talk about here tonight is just showing you the natural history of patients with prostate cancer. This is the sort of early stage diagnosis where people are diagnosed with local disease, usually treated with local therapies such as surgery and radiotherapy. And we're not going to really focus on these patients. Those patients will be treated, and some of them will never have a problem with prostate cancer again. But some of them, the PSA will start rising, and because of that, they're diagnosed as having hormone sensitive or castrate sensitive prostate cancer, in which stage manipulating the testosterone levels with anti-androgens is an important way of treating that disease. Now that will work for a period of time, and then after that the hormones will stop being completely effective, and then we've got to look at some of the other treatment options. And this is where some of the new targeted and novel anti-androgen agents come into play, and also the role of chemotherapy, and then a number of lines of chemotherapy along the way. And this is really where the focus of the talk is going to be on, not underestimating the importance of this group of patients, but obviously not something relevant for today's discussion. The TAX327 study was really the pivotal change in the way we look after prostate cancer. Now, this study was presented in about 2004, 2005, and it looked at giving patients or men with castrate-resistant prostate cancer treatment with our older treatment regimen, with a drug called mitoxantrone, versus some of the newer treatments that we looked at, Docetaxel or Taxotere, either in a 3-weekly schedule or a weekly schedule. And this was really the pivotal trial that changed the way we looked after prostate cancer. This is the survival curve from this trial, and you'll see a few survival curves during our talk tonight. The main thing that we're trying to evaluate with these curves is, does it make a difference in overall survival? If we use a new drug compared to the old drug, are we improving the overall survival? Now, it's important to remember that overall survival is not the only important endpoint. It's a very important endpoint, but also in our patients, we want to make sure that we're making them feel better, their quality of life's better, their pain's better, we're controlling the PSA, and a number of other important cofactors, but obviously survival is one of the primary endpoints of a number of these studies. Now, what these slides do is compare the two different outcomes, and whenever you can see a gap between the slides, it demonstrates that there is a survival benefit between one agent over another. And this is clearly seen in this study, and based on this study, docetaxel or Taxotere became the backbone of treatment for men with metastatic castrate-resistant prostate cancer. At the same time, there was another large international trial which showed a similar benefit and really reinforced the benefits of this treatment in this setting. Now, not only did it improve survival, but it also showed that there was an improvement in quality of life, in pain control, PSA scores, and overall symptomatic benefit. Based on that, Taxotere or docetaxel became the standard first-line treatment in men with metastatic castrate-resistant prostate cancer. The important thing to know with docetaxel, though, is that it's not relevant for everybody. We've got to weigh up the risks and benefits with each treatment that we use to see whether there's value for that individual patient of having the additional chemotherapy. And we've got to weigh up those risks and benefits. What we're trying to do better is select the right patient for the right treatment. So is it appropriate to be using a drug like docetaxel, or should we be using alternate options, or could we afford to just watch the situation for a period of time? So what we're trying to do better is select the patients who are most likely to tolerate the treatment and the patients who are most likely to benefit from treatment. The important thing about docetaxel studies, the two studies that we've just talked about, is obviously it provided a benefit for our patients, but it also changed the way the world and oncology researchers and oncologists looked at prostate cancer. For the first time, there was much excitement in research in this setting. It provided the opportunity to say, well, now what can we do together with docetaxel? What other treatment options are there? And once we'd seen a survival benefit in this situation, we knew that there was a potential to change the outcome of our patients with prostate cancer. One of the other questions that started coming forward were, what about introducing the treatment earlier? What about using the treatment in patients with hormone-sensitive disease? And we'll talk about that a bit later. And then, what about second-line treatment options? What alternate options do we have once patients have responded to the first line of treatment, and now we're looking at what we can do next when the first line of treatment stopped working? The important questions are, when is the best time to use this, and how can we best select the right patient to get this treatment? And there's ongoing research looking at that. So now that we'd established docetaxel as the first-line treatment option, this would work for a period of time, and then after that stopped working, we'd start saying, well, what are the other options? And there was an important trial called the TROPIC study, which was done and published in 2010, and that looked at patients who'd previously had docetaxel-based treatment, and now the disease had gotten worse. Could we improve things if we added a new drug called cabazitaxel? Now, cabazitaxel was the next generation of taxane, and this was a study that randomized half the patients to receive cabazitaxel versus half the patients to receive the older treatment with a drug called mitoxantrone, which is still an option in some situations. And this study, again, showed a survival benefit if you added the cabazitaxel over the standard treatment of mitoxantrone. So now what we've done is we've established that we can use docetaxel first, and when that stopped working, we had the opportunity of using another agent. Again, patient selection was very important, and that treatment was not for everyone. The next area of research was to try and see if we could do better with the androgen receptor. So in prostate cancer, what we understand is that you have a prostate cancer cell that sits with a receptor on the outside of that cell. And that receptor is looking for testosterone. And when testosterone lands in that receptor, it will make the cell grow. There are a couple of places that you get testosterone from, obviously from the testes, but you do also get some testosterone from the adrenal glands. So that's the reason why we use medications that turn the testes off, because that reduces the amount of testosterone circulating from the testes. But we also use drugs to sit in that receptor and block that receptor to stop the testosterone that's being produced by the adrenal gland. After a period of time, though, the prostate cancer cells get quite clever and say, well, you're blocking the testosterone on the inside, we'll see if we can make our own testosterone. Sorry, you're blocking the testosterone on the outside, we'll see if we can make our own testosterone on the inside. And that's where this drug, Abiraterone, became very important, because what that drug did was stopped basically the conversion of inactive testosterone to active testosterone. But not only doing it in the testes and adrenal, which used to be the main area that patients used to get their testosterone from, but it also did it within the tumor cell itself. So it bypassed the mechanism that the tumor used to escape us blocking that androgen receptor. So it was a very clever and effective way to further enhance the impact on testosterone and the testosterone receptor. So this was a very important study that was done a few years ago, and our unit was privileged enough to be involved in the study, and it was a very exciting study to be involved in because we saw results very quickly. Our patient's disease turned off very quickly, and it was very clear that this was going to be a drug that was going to be important. The subsequent studies that were presented a few years later demonstrated this with an improvement again in overall survival in these patients. Not only did it show that it improved overall survival, but this slide highlights the importance that it had on overall physical and quality of life scores. So we're seeing a drug that's a tablet, that's well tolerated, that's not a chemotherapy, that was now starting to show an improvement in survival and also an improvement in quality of life and the other factors that we talked about. It's generally very well tolerated with minimal side effects, and the main side effects being an impact on the blood tests, on the potassium levels, blood pressure, and sometimes a bit of fluid retention, but generally very well tolerated. Now this drug, the first time the study was done was to look at people once the docetaxel or Taxotere had stopped working. Now the question was, what if we bought this drug even earlier? What if we bought this drug before we used docetaxel? And there's a potential to get a benefit. If we know it works in the late stage, maybe we'll get an even further benefit if we used it earlier. And also that gives our patients an opportunity not to have chemotherapy, but to have one of these agents before we needed chemotherapy, and to potentially delay chemotherapy and the side effects of chemotherapy. So the Cougar 302 study, which was the next study, and we were involved in this study as well, looked at introducing this agent before chemotherapy in people who had metastatic disease. And again, we saw an advantage in outcome, both in survival and time to progression, and also importantly in delaying the time for our patients getting chemotherapy. So what we've seen with this drug is that we now have a drug which is a tablet that's targeting the enzymatic development from inactive testosterone to active testosterone, and we can use that after chemotherapy and also before chemotherapy with survival, quality of life, and pain benefits. The challenge we have in Australia at the moment is the approval of this drug. Now this drug is only approved in Australia for people who've been through treatment with docetaxel, and when the docetaxel stops working, there is the potential to access this drug in patients who have not had chemotherapy, but the oncologist and the team feels that it's unsafe for that person to have chemotherapy, or they're not fit enough for chemotherapy. Then this agent can be delivered in the first line setting rather than chemotherapy. So in Australia we can access this drug after you've had chemotherapy, or in people who are not suitable for chemotherapy, they can access it before chemotherapy. As I said, the side effects of this drug very well tolerated, and most people do tolerate this treatment well. It does need to be administered with a drug called prednisone, which in itself can sometimes have some side effects, but generally the combination is well tolerated. The real challenge for us now is we want to make sure our patients are accessing all of these drugs. What is the best sequence and what is the best timing of getting these drugs into our patients? So now there was a focus on the hormonal treatments. And there was another drug that was being looked at, a drug called enzalutamide or Xtandi. Now this drug works slightly differently to the Abiraterone, which worked more on the enzyme converting inactive testosterone to active testosterone. This worked more on the androgen receptor itself. But the thing about this drug is it worked very effectively against that androgen receptor, and it targeted 3 processes in that androgen receptor signaling. And by doing that, it really enhanced the impact that these agents could have on the androgen receptor. And as a result of this, an important study called the AFFIRM study was done in patients who'd previously received docetaxel, and then the docetaxel treatment had stopped working, and they were randomized to receive either enzalutamide or placebo. And the overall survival was the primary endpoint of this study, and like you've seen in a number of other studies, this also showed a survival benefit. And that survival benefit was in the order of a few months, but certainly had a significant improvement for some of our patients, again, both in the survival point of view, their symptom point of view, and quality of life as well. Similar to the experience that we talked about with Abiraterone, we showed that this drug had worked in the post-chemotherapy setting. So then the question was, well, what if we introduced it before chemotherapy? And the next trial that was done was the PREVAIL study, which also looked at using this agent in that early stage setting before chemotherapy. And again, this showed a significant survival benefit. So the message is that there are now a number of agents, each of them showing an additional survival benefit. Again, quality of life was looked at, and these graphs demonstrate that there is an improvement in quality of life and symptoms associated with this treatment. One of the other important messages that came from the enzalutamide study was that if we gave patients enzalutamide before chemotherapy, we could delay the timing of people needing chemotherapy. So for some people, that became a very important decision point in saying, if I went through enzalutamide for a period of time, could I delay the onset of giving chemotherapy? The side effects of this are also very manageable, although slightly different to the Abiraterone. The main side effect that people struggle with this treatment is significant fatigue. And sometimes we can improve that by modifying the dose and encouraging exercise, but fatigue seems to be the main problem with this treatment. So we now have another agent. We had the Abiraterone, which we talked about previously. We also now have Xtandi or enzalutamide, which has also shown a benefit in the post-chemotherapy scenario with survival, quality of life, and pain benefits. Similarly, in the pre-chemotherapy setting, survival, quality of life benefits. The approval is similar to the Abiraterone in Australia. The PBS will provide the drug for patients who have had prior chemotherapy, and it will also provide the drug for patients who the oncologist deems is not suitable for chemotherapy. So again, we have these 2 agents now which have been shown to be effective in outcome, both post-chemotherapy and pre-chemotherapy. There's a little bit of difficulty in Australia at the moment with the PBS prescribing of that. But effectively, what we want to try and do is for men who are fit enough for chemotherapy is to make sure they get access to both agents, to the chemotherapy as well as to the tablet form of treatment. So again, the sequencing of these agents is also an important issue, and one of the problems that we have in Australia is that patients are not able to access both enzalutamide and Abiraterone, and there's quite a bit of research to support the rationale for that, because it does seem that if patients have stopped responding to one of those agents, it's unlikely that you'll be able to respond to the alternate agent. So in Australia, we make a selection between enzalutamide and Abiraterone, and based on various patient factors and patient characteristics, we'll choose one drug over the other. But it's unlikely that people would benefit from having both of those agents. So really what this slide shows is that we've got a few different classes of drugs which each on their own have shown a survival benefit, and now we want to incorporate all of those into our patients' treatment to try and work out what is the best option. And clearly the elephant in the room is, what do you do, doctor? How do you choose which treatment you use? Now, I think that is a very difficult and challenging decision, and that's something that we do together with the patient based on these various factors that we've talked about. And pleasingly, I think in 2017, we actually have a lot of choices and a lot of options. And we use a number of these factors to help guide us into selecting a better treatment for our patients. And the factors that we take into account in this situation is the timing. Do we need to use treatment now, or can we afford to wait for a bit? The biology of the disease. Is this a very aggressive, biologically active disease with a lot of important organ involvement, with a lot of biologic factors like the Gleason score or the PSA doubling time suggesting that this is aggressive disease? some patient characteristics. So is the patient well enough to tolerate treatment, or what is a patient's preference? There would be some patients who would prefer to delay the chemotherapy and rather use some of the hormone treatments first, and those various factors come into play in making our decisions about what best treatment to use for the individual in front of you now. We also look at some of the toxicity factors. So we talked about the differences between the side effects of abiraterone and enzalutamide, and that would sometimes help us, guide us into which agent is better suited for the individual sitting in front of you. There's a lot of excitement in some of the new biologic agents, and we'll talk about some of those in a moment. And the other message that we keep talking about is how do we sequence all of these agents to make sure that we keep our patients on treatment for the longest possible time with the most active agents. Cost is becoming a big issue as well, and I think there's a real controversy between us as health professionals, where our priority is to do the best we can for the individual sitting in front of us, and then there's a bunch of health economists who are trying to make a decision about how is the PBS going to survive with all these additional costs. Fortunately, my role is not to be a health economist, and I need to make a decision what I think is the best for the individual sitting in front of us at the time, but obviously cost does become a big issue, and that's something that does need to be taken into account from a bigger health economic position. Now, hopefully, as we better understand the disease and better understand which patient is going to benefit from which treatment, we'll be in a better position to say, well, we're not going to give this drug to this patient because they're unlikely to get a benefit. So we spare the cost, we spare the toxicity, and just use the effective agents in patients with disease that's relevant to that particular treatment. And that's an area that is evolving, and certainly from all of the studies that we've talked about previously, there have been specimens kept, blood tests done so that they can retrospectively try and evaluate which patient benefited from each treatment so we can better select patients for the relevant treatments. So really this just highlights the same progress that we've talked about. A number of different agents, each of them showing a survival advantage. Really the next big thing happened with early prostate cancer. So we've been focusing mainly on people with castrate-resistant disease, but there was a very important study presented at the American Society meeting a couple of years ago by a friend of mine and colleague, Dr. Chris Sweeney, who works at Dana-Farber Cancer Institute in Harvard, where they looked at giving chemotherapy up front with people with hormone-sensitive disease, and it really did look like they shifted the goalposts in patients with this disease. So what their study was to look at patients with metastatic hormone-sensitive disease, where previously all that we had done with those patients was use various hormonal manipulations. With the positive results and success of docetaxel in the advanced setting, he asked the question, what if we introduced that early in the piece in these patients with more advanced and metastatic hormone-sensitive disease? And using the paradigm that prostate cancer cells had a mixture of some cells being driven by hormones and some driven by a more biologic and active process and being resistant to hormones. And if we use the combination of hormones and chemotherapy, could we improve the outcome? And that's what this trial did, where they gave patients 6 cycles of docetaxel versus plus androgen deprivation therapy versus just androgen deprivation therapy alone. And this really showed a dramatic difference in outcomes. There was about a 17-month improvement in overall survival with the early introduction of chemotherapy for these patients. And this was presented at the American Society meeting. There was much excitement about this, and really within a week of that data being published, it had become a standard of care because the impact of this change in the way we think and the way we treat hormone-sensitive disease was so great. There was a similar study called the Stampede trial, which looked at a number of different questions, but one of the questions as well looked at adding docetaxel chemotherapy early in the hormone-sensitive patient's disease process, and also confirmed this dramatic improvement in survival. Now, really the bulk of the benefit occurred for patients who had more extensive disease. So in people who've got low volume metastatic hormone-sensitive disease, it didn't seem that there was as big an impact on those patients. The impact of benefit was much greater in those people who had larger tumor burdens. As a result of this changed the standard of care, and so now what we do as oncologists for patients with hormone-sensitive disease, up front would be to give them chemotherapy together with their hormonal therapy. So again, you can see that we've changed from 2007 from having very limited treatment options to now being in a situation where we have a number of options. And I haven't discussed all of them, but it's important to know that now we have a number of choices that we can consider for our patients. I saw this slide and I had to find a way of including this in my talk. But basically, this slide looks into the future of prostate cancer. And I'm not spending a lot of time on this, but I thought it would be important just to highlight some of the things that are evolving. Now, one of the important questions, there's been a lot of interest over the last few years in immunotherapy. And immunotherapy has been really the game changer in a number of cancers, and particularly in melanoma, renal cell cancer, non-small cell lung cancer. It's become very important, with a number of trials showing significant benefits. There have been a couple of studies in prostate cancer, and we've recently just completed a study which closed a couple of months ago looking at one of the immunotherapy agents, a drug called Keytruda, and we don't know the results of that yet, but there is the potential that immunotherapy may also have a role to play in prostate cancer. We're still learning about this, and we're still trying to understand where it fits into all the other treatment options for our patients, but immunotherapy may be something that becomes a part of the way we treat this disease in the future. The other thing that's also becoming important is this concept of genetic profiling. So it is clear that there are certain genetic makeups of tumours that impact their prognosis, impact on the way the disease behaves, but also potentially offers an opportunity for intervention with some of these agents called PARP inhibitors, which are drugs that disrupt the DNA repair mechanism that's seen in some cancers. Now, the PARP inhibitors are being used in other diseases, particularly in breast cancer and in ovarian cancer, and particularly in the group of patients who have this genetic mutation called a BRCA mutation. Now, there was an important study that was presented in the New England Journal a few months ago looking at screening everyone with prostate cancer, and they found that about 13% of people had a particular genetic mutation which may have made the disease amenable to some of these new treatments. And that's something that's being included in ongoing research at the moment. And we were also involved in a study looking at a PARP inhibitor in patients who had this particular genetic mutation. Now, we need more research to see whether this is likely to have a major impact and whether this is going to become a part of our treatment paradigms in the future. One of the other things that I've tried to avoid from a treatment screening point of view or imaging point of view is the PSMA scan, and that's obviously become a very important tool that we use in certain situations. Basically, what PSMA is radioactively labeled protein that targets PSA in the bloodstream and finds areas where there is active disease, and we can do a scan that can show those relevant hotspots. So it's a very sensitive way of picking up disease. Probably, well, it is more sensitive than bone scans and CT scans. It's not relevant for every situation, but in certain situations, a PSMA scan may be an important test to help us with some of the decisions that we make along the way. Now, there's been a bit of research of late looking at labeling that PSMA with a protein that is radioactive. So effectively what you're doing is you're seeking out where the areas of PSMA avidity are, and targeted to that protein that binds to it is a radioactive protein that then basically blasts the tumor in that particular area. And that's something that's an area of ongoing research at the moment, and again, maybe an option for down the track for our patients. And there are a number of studies looking at that particular issue at the moment, where some of our patients would be involved in those trials. So I think in summary, you can see that this is a rapidly evolving space. The goalposts keep changing. As we get to a particular line of treatment, we see that, well, there's something new now. How do we need to fit that in to all the old stuff that we knew? I think it is fair to say that the standard of treatment, first line, particularly in Australia, in men who are fit enough to tolerate it, would be Docetaxel, Taxotere. There is some debate about using some of those targeted hormone tablets, the Abiraterone or enzalutamide, pre-Docetaxel. It is a bit restrictive in Australia at the moment with that, but there is the potential for that in certain situations. We know that there is a benefit of those agents after chemotherapy, and now what we've got to do is just debate in the individual patients that we're seeing what's the best order to administer these drugs. It's also very important that we focused a lot on some of these drugs that help with improving patients' outcomes, improving survivals. There is a lot of supportive care that's required in looking after our patients with this disease. Now, obviously, it's not within the scope of our discussions today to go through that in more detail, but just to highlight the importance of looking after the whole patient. So it's looking after the pain that may occur, and it's very important that we make sure we optimize that and control that well. Looking after all the other metabolic symptoms and issues that arise with people being on androgen deprivation therapy. So making sure we're looking after their bone health, their cardiovascular issues, diabetes, cholesterol, all of those important factors. There's a lot of psychological and social support that's needed in looking after our patients, and other using the combination of our radiation oncologists and neurologists and other specialty areas to make sure that we're covering all the areas that are important in looking after our patients. So going back to the conclusions that we talked about at the beginning, I may conclude with them again, just to highlight that I think each patient is treated as an individual. Each patient's disease and each patient's condition that they come to you with the disease is individual, and the treatment needs to be tailored accordingly. I think you can see that there has been definite progress in the last 10 or 15 years, and the way that we treat prostate cancer now is quite different, and our patient outcomes are dramatically better. We have a number of options. There's still ongoing issues about how we sequence and when we start the various treatments. I hope that people can feel that there is much optimism in outcomes for our patients and enthusiasm in pushing research and pushing clinical trials, because that's the way that we're going to continue to shift the goalposts in both the treatment and diagnosis of our patients. And getting people involved in clinical trials is an important way that they can access some of the newer agents now, but also a way to improve the overall outcomes of our patients. And I may stop there and give you some time for some questions. Thank you.
I have one. I noticed from the slides, prednisone is used with a lot of the drugs.
Yep.
What is the purpose of the prednisone?
So that's an excellent question. The story of prednisone in prostate cancer is, some of it is actually a little bit historical. So basically in the 90s, or the 95 or so, we didn't really have much treatment option for many treatment options for our patients with prostate cancer. There was a trial that looked at giving patients prednisone, 5 milligrams twice a day, and that actually improved the PSA, and it improved patients' feeling of well-being and symptoms as well. So that became the new standard of care. Then there was an important study that was led by Ian Tannock in Canada, which looked at giving mitoxantrone, which was the first chemotherapy that showed some activity in prostate cancer, versus prednisone. But because at that stage they didn't know whether the mitoxantrone was going to work, and we already knew that the prednisone had some quality of life and symptomatic benefit, it would be unethical to do a trial where you didn't give patients prednisone, because if you gave them mitoxantrone and it didn't work, you'd be disadvantaging them compared to what was the best standard of care at the time. And that's an important concept. With any trial that we do, we want to make sure that what the experimental arm is at least equates to what we think the best standard of care at the time is. So based on that, the original trial looked at mitoxantrone plus prednisone versus prednisone, and it showed that mitoxantrone and prednisone was better. So mitoxantrone and prednisone became the new standard of care. Then when the Taxotere study was being tested, they said, okay, well, let's check if Taxotere works better than mitoxantrone and prednisone. And at that stage, we didn't know whether Taxotere was going to be effective, and we knew that the prednisone contributed, so we thought, well, it's not fair to do a trial with just Taxotere if they're missing out on prednisone, which may be an active agent. So the trial went Taxotere plus prednisone versus mitoxantrone and prednisone. And Taxotere was found to be a better treatment, but it wasn't just Taxotere, it was the Taxotere plus prednisone package. So, and that kind of evolved with each of the treatments that we used, was because prednisone was always considered an important part of the standard of care, it needed to be included. Now, there are some situations where if patients are getting side effects from the prednisone, we'd sometimes cut the dose back or sometimes miss the dose, but it's basically part of the package. Now, the one area where it is actually biologically critical, biochemically critical, that you are on prednisone as well as the agent is with abiraterone, because abiraterone does have a direct impact on the adrenal cortex, which is, the adrenal gland, which is producing effectively prednisone. So with that treatment, prednisone is an important part of the package for biochemical reasons, whereas for most of the others, it's probably more for historical reasons.
Right. Thank you, Gavin.
Right. Would an orchidectomy ever be considered before any of these other treatments start, or is that old-fashioned?
No, an orchidectomy is a very effective way of reducing the testosterone. So the options for reducing the testosterone is either to do an orchidectomy or to use the drugs that block the pituitary gland, that stop the message going from the pituitary gland to the testes to produce testosterone. Now, in some countries, orchidectomy is accepted as the standard of care. And certainly from a cost-effective point of view, it's a definitive way of getting rid of the testosterone. And it is much more cost-effective rather than giving the injections every month or 3 months. But it's something that culturally is not quite as acceptable to men in Australia. And so in Australia, we tend not to do it very much, but it is a very reasonable treatment and it is a very effective treatment. I suppose one of the only issues with that, aside from the psychological concerns for some men, is that it's also irreversible. So if we use the LHRH agonists or the LHRH antagonists, the drugs that affect the pituitary to stop testosterone production, in time, if you stop that drug, so for example, if a man was having a terrible time with having no testosterone, if you stop those drugs, often the testosterone levels will drift back up again, and you can, overcome some of those symptoms. Obviously, at compromise to the outcome of the prostate cancer, but it is not, the orchidectomy is an irreversible situation. In a lot of countries, and there are a lot of people, talking from a cost-effective point of view, saying, well, why are we doing these injections every month or 3 months, which cost a lot of money, when we can just do an effective treatment? And the other thing with orchidectomy is that that it's done and it's sorted, whereas the injections rely on people showing up every month, 2 months, 4 months, or 6 months, or whatever. And so there's compliance issues, and there is sometimes a problem with the injection actually converting to getting complete castrate levels of testosterone. So very good question, very good option, just not really done very much in Australia. Yeah.
Question, Debbie?
Yes. I've been asked to volunteer for medical student training in the area of andrology because the 2 undescended testes operations in childhood effectively castrated me because they were unsuccessful. That's my scan for prostate cancer, and it shows that above the pelvis,
yes,
I am not normal. I'm the body of a boy, not transformed properly to a male.
Right.
Below the pelvis, it's normal male of my age. This has a major effect on the treatment I could have for the prostate cancer. 4 radiation oncologists got it wrong. I had to go to an andrologist trained in Harley Street, London, to find that I had to have Professor Henry Wu's surgery, and that's been successful. It needs to be in a website somewhere because it's not in the medical literature. Most males with my condition suicide before diagnosis by a GP, and the GPs don't know which specialist to send the patient to. There are really major problems in this area.
Yeah.
I've volunteered for medical student training with a number of universities.
Right.
I'm trying to find where to volunteer here at this hospital. A lot of people are very interested, in particular my haematologist, but you might be able to help.
Look, I don't know exactly but I mean, maybe we could talk afterwards. I mean, I'm involved with Sydney University, and I'm sure there would be people here who would be very grateful for your willing to contribute to education, and there are definitely ways that we'd be wanting to take advantage of that if we could, and learn from that, and I'm sure it'd be great for our students. I suppose just on the surface, I think the people who probably be the most able to guide us would be the endocrinologist, because I think this would be more their area of expertise rather than mine. But I'm happy to put you in touch with people so that we can educate people about some of these rarer conditions. And I think you're right. It's important that education around that is what is needed. Yeah.
Oh, Gavin, I much enjoyed your talk. This issue of medical determined versus government constraints that the industry seems to have. How much progress is actually being made, and how much of a real impediment to good medicine or the best medicine is in fact the case? Yeah,
look, I think that's overall, I think that the system in Australia is very fair. I think we are able to access a number of drugs that are available, and certainly much more so than a number of other countries. Obviously, there is some frustration in the timing of approval of some of the agents that we've seen in the research that look like they're effective, and getting them to market or getting them to become affordable on the PBS is difficult. Now, I think the PBS juggle a very difficult problem, because clearly the way that medications and options are going for our patients with malignancies, the costs are going to become really unaffordable for a country. And it is a challenge, and I'm not sure that there's a simple answer to fix that. I do think, though, that obviously there are a couple of agents that we really feel that the chain's been dragged, and it's not getting approved as fast as we would like. But I think most drugs are available for our patients here. Sometimes there are some barriers or timing of how we need to give them, which complicates things a bit. Obviously, as a medical oncologist with a patient sitting in front of you, when I know that there's a drug that may be of benefit and it's not going to be available unless the patient pays for it, or there's some other way that we can get that drug, that is frustrating and that is difficult. But I don't envy the people in the position who are making the decisions about what is to be paid for and what's not to be paid for. And so it is a balance. And one of the other issues are that when we do trials, so there's some agents that demonstrate a small additional benefit. How do you quantify the meaning of that benefit to the individual sitting in front of you? So if we see a drug where there's a 6-week survival benefit on average, how do you justify that benefit cost-wise to the community? But more importantly, the problem is, what that means is that there will be some people who get no benefit and some people who get less than 6-week benefits, but there's going to be some people who get significantly more benefit. And really, I think the thing that is going to make this continuous rising cost of treatments affordable is to be able to not give the people the treatment who are not going to get a benefit, because that still costs the government. So if you land up halving the cost of the drugs just by selecting the right people, so you say, look, this patient's not going to get a benefit, that drug's not available for them, this person is going to get a benefit, it comes on, and that's the problem, is that we're not close enough to the point where we can really be specific for accessing certain drugs. Now, there are some drugs, not so much in prostate cancer, in other diseases where there's a particular mutation, even though that mutation is very rare, but if you have that mutation, you will get a dramatic benefit, and those drugs get approved very quickly because it's a small number of people who get a dramatic benefit. Whereas if we gave that same drug to the whole population, the net effect of that, the result will be negative and the cost would be unaffordable. So it's part of the issue is us as researchers and people involved in pharma and research trying to really hone in on identifying the people who are going to get the main benefit, and those people should be treated with the drug, and then it becomes cost effective and toxicity effective as well, because you're not exposing people to a treatment that's not going to be of any value to them. But it's a tricky balance.
I guess it's the main issue was the sequencing aspect of it, and I just question whether do you have the same issues within prostate cancer as you, or do you have the same issues with people with, let's say, breast cancer, and as opposed to prostate cancer, and are they dealt in more or less the same way?
It's probably, there really is a sticking point in this oral treatment and the timing of it with docetaxel in prostate cancer. Now, some of it goes back to, some older research. So the first research that was done with both of those agents, and I presented the trials in order of the publication. So the first publication tested it after Taxotere, and that's what justified its benefit, but that drug showed that it was effective after Taxotere. So when the government approve it, they approve it on that basis. They're still reviewing the validity and the value of using that drug before Taxotere, because that study happened later. And the same with the Abiraterone and enzalutamide, the post-Taxotere treatments were first. So those data are more mature, and so that drug gets approved first. So they've approved it on evidence, but there is now subsequent evidence that shows that, there's also value if you used it earlier. But that's something that still goes through the process, and that process is a slow process. So in certain other diseases, there are some drugs that if you use, so in breast cancer and in pancreatic cancer, there's certain drugs that if you use them in the wrong order, then you limit the option of using the other drug. And a lot of that is based on the original study that was done, which showed you did this, then that's the way the drugs get approved. But often there is a bit of a lag from the progress that happens in research to the time that it gets approved from the government. But overall, I think we do get access to a lot of agents here that we don't get elsewhere. Obviously I want more, but